Okay, hi everyone. Can I just check that you all can hear me before I make a start? Because I'm in a room that I don't usually work from, so I just want to check that you can hear me. A thumbs up or yeah, perfect. So I think most of you have met me by now. My name is Nishma. I'm one of the critical care pharmacists. Today's session, we will be looking at the kidneys and the renal replacement therapy. So hopefully all of you guys have had a chance to have a look at the material that we posted on the Google Classroom. I have Razi with me. She's one of my colleagues in the critical care team, one of our pharmacists, and she'll be helping to facilitate the session today. So as we usually do, if you have any questions, feel free to pop them in the chat or raise your hand, and we can try and work through them as we go along. And anything we've missed out on, we'll come back to at the end. It's quite an interactive session today, so it'll be great if people want to come onto their mic or if you want to pop things into the chat. And it's very much based around scenario type questions, so hopefully it's useful to you all. So I'm just going to share my screen and we can make a start. Okay. So we're going to kick off with a question to begin with. This is aimed for the technicians on the call, but if of course all the pharmacists online can also answer. So the first question is, you have a patient with known CKD. They're usually on dialysis 3 times a week. What questions would you need to ask the patient with regards to their medications? And are there any particular drugs that you would need to ask more information about? So you can either, if Slido doesn't work for you, you can type some answers in the chat. Otherwise, if you scan that QR code or go to the website and put that code in, it should bring you to the question. Phosphate binders, definitely a good one. Yeah. Aspirin, that's an interesting one. Lithium. Yeah. So any drugs that I guess, well, if their clearance is affected by the kidneys, we would need to know more information about those. Timings around dialysis sessions, definitely a key one, and days of dialysis. Because as some of you already pointed out, there may be days of the week that they take the medications in time with their dialysis, and so they may not take some of their medications every day. NSAIDs, ACE inhibitors are a good one because we try to avoid those in CKD and AKI. Vitamin D is also a good one. Darbepoetin, yep. And a lot of these medications, especially in the UK, we find that they sometimes are not prescribed by the patient's GP. So if you call the patient's GP and ask them for a history, you may not be able to get these medications because they're supplied by their renal clinic or their hospital. So with our CKD patients, especially all those on filter or dialysis, we need to make sure that we've consulted all their various clinics and hospitals and GPs to get a full picture of their drug history. I'll give you guys a few more minutes to see if anything comes up. I can see that aspirin has come up quite a lot, and it would be interesting to see why aspirin has been the drug of choice. Does anyone want to come onto the mic or type in the chat why that would be something you'd be, wanting to ask the patient more about with CKD? Mm. Razi, is anything in the chat with regards to the aspirin?
There's nothing at the moment.
Nothing at the moment. Okay. Does anyone want to come on the mic? Usually aspirin doesn't come up for us as kind of like one of the key drugs. I'm just wondering what the reasons are behind that one. Is it just a bleeding risk or is there anything else that we're missing? No? No one's brave enough to come onto the mic. Feel free to type in the chat if anyone has put aspirin down. It'd just be interesting to hear. But yeah, all good answers. So we'll move on to the next slide.
Nishma, we have NSAIDs, including aspirin.
Okay.
It can inhibit activity of COX enzymes and therefore
Yep.
reduce renal induce renal ischemia and decline the renal function.
Good answers. Thank you. Okay. Oh, not too far. Oops. Sorry, let me just come on. Skip the base slide. Let's go back. Sorry. Bear with me, my computer has frozen. Okay, can you still see that?
Yes, we can see the case studies.
Amazing. Okay, so we're going to start with a quick question. So you have a 58-year-old male who has developed septic shock. They've got AKI and they're oliguric, and they've been trialed on aggressive fluid resuscitation. He's now becoming more hemodynamically unstable. So the question will be, would you start renal replacement therapy for this patient? So it would be yes, no, or unsure. We've got lots of you voting. Can I just check how many on the call, Razi? Roughly, so.
Around 27?
Okay. It's a few more minutes. One more minute and then we can move on to the next slide. So the majority of you have gone with yes, and I would agree with you. Anyone on the call want to give a reason why they would have said yes for this patient? Either want to type the answer in the chat or you can come onto the mic. So why would you start renal replacement therapy for this patient? Someone want to come on? No? Anything in the chat, Rosie? No?
They've just said patient has septic shock, so it increases the mortality risk.
Yep. So as you can tell from the case, the patient is very, very unwell. They have tried fluid resuscitation, and they're just becoming more and more unstable. So it would be a point where we would consider to start renal replacement therapy for this patient. So the correct answer would be yes in this case. So we're going to move on to the next one. So in this situation, you have a 45-year-old woman. So she's got CKD and she's got mild hyperkalemia. So she's got some high potassium as well as some fluid overload. Her urine output is 0.8 mils per kilo per hour, and she has no signs of severe acidosis or uremic symptoms. Which of the following would be the most appropriate management for her? So she's got CKD, she's got a little bit of hyperkalemia, she's fluid overloaded. We've got her urine output there, which is 0.8 mils per kilo per hour. No acidosis. So your options are you could either start filtration for her, you can manage conservatively with some diuretics and medical therapy, you could do nothing, leave her as it is, or you could hold nephrotoxic drugs. So what would be the most appropriate management for her? Okay, so the most of you have voted for managing conservatively with diuretics and medical therapy. A few of you have said hold any nephrotoxic drugs. I'll give you a couple more minutes to vote. We've got 28 on the call, so I'll give you a couple more minutes, a few more of you can vote. Okay, so let's discuss this one. So the majority of you have said manage conservatively with diuretics and medical therapy or hold nephrotoxic drugs. So both of those are the correct answer. And the reason being, does anyone want any discussion around why did we go with just managing the patient conservatively with diuretics? Why wouldn't you start a filter for this patient? Any thoughts? Again, happy for you to come on the mic, or you can type your answers in the chat.
Yeah, I mean, her urine output is above the 0.5 ml per kilo per hour.
Exactly.
First of all.
Yeah.
She's not showing any signs of metabolic acidosis.
Mhm.
So at this point, rather than go whole hog with the filtration, I'd be inclined to go with diuretics, which are going to help to pull off potassium anyway.
Yeah.
Hope to get her back in range without the invasive treatment.
Yeah, exactly. Perfect answer. So yeah, exactly that. So she's got good urine output. She doesn't have any signs of acidosis or uremia at this stage, and her hyperkalemia is mild. So yeah, we would still look to hold any nephrotoxic drugs because obviously we don't want to worsen the situation. But yeah, we wouldn't look to start a filter in this case. Okay. Next scenario question. So you have a 70-year-old patient with a background of decompensated liver failure due to excess alcohol. They present to your ICU with confusion and suspected AKI. You notice from the bloods that there hasn't been any serum creatinine available for the last 3 days. So what would be your approach to assess and manage the patient's renal function? So what are your options? What things could you look at, bearing in mind that you haven't got a creatinine for the last 3 days? Yes, urine output would definitely be a good marker. So someone has mentioned creatinine, but you don't have creatinine available. So you'd have to think about what are your other options if you didn't have creatinine. So that's usually our kind of gold standard that we would use. Okay. Lots of you have said, oh, let me just make sure we all have our mics on mute, please, unless you're answering a question. I'll give you a couple more seconds to think about if there's anything else you could think about in this case. Look at urine output. Yep, urea. Urea is a good one as well. Okay, so the urine output is definitely probably the gold standard marker that we would use. The other one that actually I've noticed no one has mentioned is enzymatic creatinine. So this is something that we can sometimes request for our patients. It's not always available immediately. But when we have patients who have, severe liver failure, it can affect the way their kidneys been produced and broken down. And in the presence of acute kidney injury, that can be worsened. If their bilirubin's high, that can also interfere with creatinine results as well. So what we do sometimes request is a special test called enzymatic creatinine. And we can use that as an alternative marker if we don't have the normal creatinine available. But again, all the other types of approaches that you have listed would be what we would do in practice as well. So we would look at fluid balance, We don't actually use cystatin C here. I don't know too much about that, to be honest. It's not something we use in the UK. Ultrasound, I guess if it was a really severe, episode of AKI or CKD where you needed to have a look at something urgently, could be an option, but wouldn't be our kind of, first method of assessing the patient's renal function. But all good answers there. Thank you. We'll move on to the next one.
Nishma, we just have a question?
Yeah, of course.
Someone's asked, how do you interpret enzymatic and creatinine? It's not something that they routinely do in their unit.
So actually, when the lab we request it from the labs, it just comes up as a value. So the value is very similar to creatinine actually. So like a normal creatinine might be between just ballpark 50 to 90, for example. So the result actually comes up to a very similar value to that. And so we would interpret that value as we would normal creatinine. So we would work out an estimated creatinine clearance, and then we would use that alongside urine output and then work out a rough creatinine clearance. So we would use it the same way as normal creatinine. Any other questions?
Not at the moment.
Thank you. Okay, I'm going to move on to the next few questions or discussions will be around renal replacement therapy. So this is, I guess, one of the main things that you will see in critical care that you won't see on a normal ward. So I guess it's one of the good things to kind of go a little bit deeper into and go through the kind of scenarios that you may face with patients on renal replacement therapy. So I know we've got about 28 people on the call. It'll be good to just see what type of renal replacement therapy you use where you work, or if you use it at all. I know some places might not be using it at all. Good to see kind of the range that we have. I'll give you a couple of minutes for that one. Okay, so it looks like the majority of you use continuous hemodiafiltration using citrate, which is what we use here at UCLH. And the next common one is hemodialysis, again, quite a common one with a lot of our UK hospitals. We will go into a little bit about the anticoagulation in the coming slides, so I'll go into that a little bit later. But thank you for that. So when we're looking at the different types of renal replacement therapy, this slide is just a little bit of a refresher of how the filters work. So hemodialysis involves the process of diffusion, and that method of renal replacement therapy can remove molecules of up to 1,500 Daltons. So if you look at the slide on the right-hand side, it's majority of all the small and medium-sized molecules can be removed by hemodialysis. With hemofiltration, it works using convection, and that can actually remove particles of molecules of up to 50,000 Daltons, which is including quite a lot of the large molecules as well, if you look on the right-hand side slide. And then hemodiafiltration is found to be the most effective method because it uses both diffusion and convection and can remove a lot of the larger size molecules as well. So here at UCLH, we use CVVHDF, which it sounds like a lot of you on the call also use. So this is a continuous method of renal replacement therapy, and it works over 24 hours. And because it's quite a gradual process and it mimics how our kidneys work, so our kidneys are filtrating continuously over 24 hours, it builds quite a homeostasis and tries to keep a normal kidney function throughout the day because it mimics what our usual kidneys would do over 24 hours. So it seemed to be quite an effective method of renal replacement therapy. These are just a few diagrams which you would have seen on the pre-recorded material. Just a little bit of a refresher of how the filters are built, I guess. What we do is obviously try to mimic our kidneys. And as you can see from the pictures, the different lines that we have tried to mimic the different parts of the kidney. So the access line on the filter will mimic a renal artery. The return line will mimic a vein. The actual filter would be the kidneys. And then the filtrate lines, which the waste will go through, will mimic a urethra. And then you've got the drainage bag, which acts as a bladder. So it's very cleverly made. And this diagram here shows what a filter actually looks like close up. And again, the way that they have made the filters using membranes and the fibers try to mimic the nephron and what that looks like and how that works. So it's really cleverly designed and tries to mimic the kidney as best it can. So a couple more recap bits of information, which I think is just important to kind of go through. So we know that when we talk about renal replacement therapy, we do have the dialysate bag, which is linked to the patient. And what we try to do with the dialysate bag is that the components of the bag are set at particular amounts. So if you look at this diagram, the bag contains 4 millimoles of potassium, 2.5 of calcium, 32 of bicarbonate, 140 of sodium, and 1.5 of magnesium. So in this patient, what we do is the way the bag works, the bag runs in the opposite direction to the blood flow, so counter-current flow, and molecules move from an area of high concentration to an area of low concentration. So in this patient, in the blood, they've got a potassium of 6.8, so they've got some kind of hyperkalemia going on. Because the bag only has 4 millimoles, that 6.8 is a higher concentration, so it gets drawn out of the blood into the dialysate. So essentially, it's correcting the hyperkalemia. Similarly to the calcium, it goes from an area of high to low. In this case, the patient's got a low bicarbonate, so the bicarbonate will move from the dialysate bag into the blood. And in that way, because it moves in the opposite direction to the blood, and the molecules are moving from an area of high concentration to a low concentration, we're correcting, the patient's electrolyte balance in that way. So the dialysate is made up of water, electrolytes, and salts. And as mentioned, it pulls toxins out from the blood and into the dialysate bag, which then gets removed from the patient. The picture on the right just shows you what we use here at UCLH. So you may use similar bags or similar compositions. So the dialysate bag that we use here is called Prismocal. And these are, this is made up of, a combination of different electrolytes and salts, as you can see. And so that's just a few examples that you may see. It'd be good to have a look at what you use at your hospital and kind of what the components are made up of. So we have another question. So this is regarding renal replacement therapy. So you have a patient on renal replacement therapy, and currently they are running on 1 litre of dialysate fluid, 1 litre of anticoagulant fluid, and 200 mils of replacement fluid per hour. So this is per hour. So how many bags of each fluid will you need to cover a weekend? So this will be 3 days, Friday, Saturday, and Sunday. And note that each bag is 5 litres. So a little bit of a calculation question. This is something that we have to do in practice. We get our technicians involved with this as well. So sometimes we need to work out, for example, if we have a bank holiday, we're not going to be around. We need to work out how many bags we will need to supply for a patient. So this is your scenario. Which one would you say is the correct answer in this case? How many will you need for one patient? This is. Okay, a couple more minutes. Okay, so I've got back majority of you have voted. Did any, so it looks like the majority have voted for the 15 bags. Razi, did you, I don't know if you had a chance to work this out. Did you get the same answer or anything different?
I haven't had a chance yet.
Anyone in the chat have anything different to what's on there?
There's nothing in the chat.
No? Okay, does anyone want to talk through how they got their answer? So it looks like nobody has voted for the 30 bags. A few of you have voted for the 20. Does anyone, oh, sorry, is that someone on the
That's
call?
right. So I converted it to how much you'd use in a typical day. So for instance, dialysate, you'd be using 1 litre per hour.
Yeah.
Times that over 24 hours, you're using 24 litres a day.
Yep.
Times that by the 3-day period, which would give you 72. And then
Yep.
divide that by the 5 litre bags, which would give you 15 bags.
Perfect answer. Yeah. So I guess the thing that you have to bear in mind with this question, which can confuse sometimes the nurses or with us in pharmacies, to have a look at the bag sizes that you have. I think all of our bags are 5 litres. So have a look at the kind of the stock that you keep where you work, and sometimes you do have to do a quick calculation, especially if it's per hour and you're kind of covering a long period of time. But great, thank you. So we talked about anticoagulation a little bit earlier. It'd be good to see, for those of you on the call, what type of anticoagulation do you use for your renal replacement therapy where you work? Okay, so the majority is citrate. As I mentioned before, that's what we use at our trust here. And I guess the second most common is heparin. Again, it's very similar to what we use in UK hospitals. It is between the two, citrate and heparin. Does anyone want to mention what are the pros of using citrate over heparin? Any pros of using citrate over heparin?
Prevents clotting in the filter.
Yes, there's lots of evidence to show that the filter time essentially is longer than if we would use heparin. So yeah, that's true. Anything else?
Less risk of hemorrhage in the patient.
Yes, that's probably one of the biggest pros, less bleeding.
It can also maintain the normal patient calcium levels.
Yes, it can. And I'll go into a little bit about that on my next few slides. Anything else? No. I think you've covered probably all of them. The other one is, I guess, cost-wise, it has been shown to be more cost-effective than heparin. In our trust, we don't actually use heparin at all throughout the trust. We have had errors with, risk of bleeding with the monitoring, and I guess in terms of administration and a safer option for nurses. I guess that's another pro that we would go for in our trust as well. So thank you for that. So a little bit about how citrate anticoagulation works for those of you who don't use citrate. I won't go into this into too much detail, but this is essentially your clotting cascade in the body. And the way it works, if you can see, or I could just point to it on the screen here, the clotting cascade involves calcium in a lot of its different stages here. So citrate works by binding to the calcium, which then essentially stops the clotting cascade from proceeding further. So that's a very simplified version. But you can see here throughout, both pathways, you've got calcium involved in a lot of the stages, and so that's how it helps to prevent coagulation. Okay, so we have another scenario question for you. So you have a 65-year-old patient who's on continuous venous hemodiafiltration. They have a history of recent intracranial hemorrhage and currently have active GI bleeding. What would be the safest anticoagulation strategies for this patient? So they've got some active bleeding, they've got a history of recent bleeding, and they're also on filter. So your options are, you can increase the dose of anticoagulation to reduce the clotting risk without increasing the bleeding risk. Give systemic anticoagulation, as that has minimal bleeding risk and can be continued safely despite active bleeding. You can avoid systemic anticoagulation to reduce bleeding complications, or you can give regional citrate anticoagulation or no coagulation. What would you say would be the safest option for this patient? Okay, so I'm glad that nobody said to increase the dose of anticoagulation or giving systemic anticoagulation, because both of those would increase the risk of bleeding. So the two correct answers would be to, agree, avoid any systemic anticoagulation. So that would be giving like a low molecular weight heparin, for example, and definitely to go with regional citrate as your first option, or no anticoagulation. So in practice, we have had scenarios where the patient has a high risk of bleeding, or their platelet count is very low and they may not be appropriate for any type of anticoagulation. So we have used no anticoagulation before, and you just have to monitor the filter for clotting. So it can be an option if for example, you can't use citrate anticoagulation either. So yeah. So option to use no anticoagulation, as I mentioned, when would we consider to go for this option for a patient on a filter? So if they've got some kind of coagulopathy going on, if they've got a higher INR, if their APTT is raised more than 60 seconds, if their platelet count is less than 50, or as we said, they've got a high risk of bleeding. For patients on a filter, we do try to ensure that we do have anticoagulation where possible, if it's appropriate. And as we've mentioned, the aim is to anticoagulate the filter and not the patient. So we would always aim for regional anticoagulation as opposed to systemic anticoagulation. So this is a question that we frequently do get asked in practice. What do you do if you have a patient who is on renal replacement therapy, but also requires VTE thromboprophylaxis? So this isn't a Slido question, so happy for you to comment to the mic or type in the chat. What do you do in practice? So you've got someone on a filter, but they also need VTE thromboprophylaxis. What are your options, or what would you do? I can't see the chat. I don't know if Razi, there's anything.
Yes, we have some answers. So
Yeah.
for citrate, they normally use low dose enoxaparin if less than 100 kilos, so 20 milligrams once a day.
Yeah.
Some others usually give heparin if there's no contraindications.
Okay. So yeah, I guess dependent on where you work, you will have different options. If you are a trust that uses heparin, they do use unfractionated heparin as an option. Here, where we work at UCLH, we do give enoxaparin, so that's our choice of low molecular weight heparin. We would actually give a full dose. So for us, that would be 40 milligrams once a day for an average weight patient. With our filters on the lowest level, the lowest rate that we use, the renal function is estimated to be over 30 mils per minute, just over 30 mils per minute. So we would give the full dose unless we're worried about, any risk of bleeding or anything like that. So we would give the full 40 once a day. Another question, would you give both low molecular weight heparin or heparin and regional anticoagulation? So I guess for those of you who said heparin, would you give heparin and regional anticoagulation, or would you just give the heparin?
No, they just use heparin.
Yep, that's the safest option. For us, obviously, because we use the citrate, we do tend to use both together. So we would use low molecular weight heparin for the VTE thromboprophylaxis side, and then we would use regional citrate for the filter. The other option, if you have a patient on a filter, but you're really, really worried about, bleeding and it's contraindicated to give heparin or low molecular weight heparin, you could give Flowtron, so TED stockings or a type of electronic stockings or mechanical stockings that you could give as a precaution if giving a type of thromboprophylaxis is not suitable. Okay, another question that we also get is, how do you work out the estimated renal function for a patient on renal replacement therapy? So again, this is dependent on where you work and what type of filter you use. But what methods do you use where you work for calculating estimated renal function on a filter? Okay, so we've got lots of good answers coming through. I like the honesty for those of you who said, I find this very challenging or it's unknown. Some of you have said you just look at the CVV-HDF section on the renal drug database for dosing. So yeah, I think this is quite a universal issue. So everyone you speak to has a different method, a different resource they use, a different method in practice. So there isn't a right or wrong answer. But what I'm going to talk through on the next slide is what we do here at UCLH, and maybe it might help some of you if you find it challenging or not sure how you can do it in practice. So at UCLH we use, as I've said, is the CVV-HDF. And for a patient who is on hemofiltration, the estimated GFR is produced by the filter is determined by the filtration rate, the degree of pre-dilution, and the blood flow. And obviously we use different rates, which are done by adjusting the dialysis solutions and the ultrafiltration rates. And different rates allow for more or less removal of water and waste products. So what we do at UCLH is we actually add all the filter fluids that are running through the patient, and we divide it by 60, which will give you a mils per hour. So just to give you an example, so we have the blood flow here, which is 100 mils per minute. Do you remember the diagram that I showed you earlier? We had a picture of the blood running in one direction, and then you've got your dialysate bag running in the opposite direction. So this is the flow of the blood. And this setting that we start off with here is we call it our lowest level or a level 1 filter. So what essentially we do is a very simplified version. At the bottom there, I've actually put an equation that can be used to actually calculate it in a lot of detail. But in practice, when you've got lots of patients, you don't have a lot of time. We've come up with a simplified version, and what we do is essentially add them all together. So we add up the anticoagulant, the dialysate bag, and the replacement bag. So that's 2,200 in this example, divided by 60. And then that will give you an estimated GFR of 36 mils per minute. So a level 1 patient would be approximately 36. A level 2 will be a little bit higher, in about 40 odd mils per minute, and then level 3 would be 50 odd mils per minute. So that's a very simplified version that you could use where you work if you do use CVV-HDF as an example. This equation is also on the pre-recorded material. It can be something that you could trial in practice what we have done actually here at UCLH is we have an electronic system, and we have something called a flow sheet, which is on our prescriptions. And actually our system now automatically works out this equation. So the nurses will put in what the blood flow is, how much of each renal replacement fluid they are using per hour, and then the electronic system cleverly actually calculates that automatically. So that could be something to look at if you're using an electronic system where you work. If you have some clever people in your IT team who will be able to kind of program this flow sheet for you, that then it actually saves a lot of time as well than having to kind of work out this formula every day for your patients. We're gonna work through that example just using a case study. So we've got a patient who has got sepsis and new AKI. They've got a past medical history of diabetes, hypertension, high cholesterol, and neuropathic pain. There's a list there of some of their pre-admission medications. So they're on amlodipine, atorvastatin, metformin, omeprazole, ramipril, and gabapentin. And on admission, their creatinine is 140. So this is the only information that you have at this stage. What other information might be useful to you? Okay, so we'll just talk through a few of these. Lots of you have said weight and gender, and I assume that will be to help you work out the creatinine clearance of the patient. Urine output would be a good marker as well to see how bad the AKI is. Baseline creatinine as well is important to see, you know, if this is a AKI on CKD or is this a completely new AKI. What else do we have? Potassium, yep, that might give an indication of how bad the AKI is. So yeah, lots of good answers there. So for this patient, they were started on an antibiotic, so ceftazidime, 2 grams. Oh, Razi, sorry, do you have a question?
Yes, we have a question. Can you just run through whether ideal body weight or actual body weight is used to determine the rates?
With regards to the filter rates?
Yeah.
We actually use actual body weight in practice. So we wouldn't. What we would do is, let's say, for example, if the patient is around 7, like if we take an average of 60 to 70 kilos, we would start at a level 1 or kind of like the lower rate filter. If they are 90 and above, then we would start them at a level 2 or potentially a level 3, depending on what their presenting complaint is. So for the average rate, we would start about level 1, and anyone 90 and above, we would go for 2 or 3. Is that okay?
Yes, we've got a thumbs up.
Okay, perfect. Thank you. So back to this patient, starting on some antibiotics, so ceftazidime 2 grams 3 times a day for day 1. We've continued on this for 24 hours. And then now, day 2 and day 3, we see that the creatinine is starting to worsen and worsen. So it's gone from 140 on admission to now day 3, which is 650. So the decision was to start the patient on a filter. Oops, sorry, go back. Decision to start the patient on a filter. And we're assuming that they're starting on a level 1 or the lowest rate, which will be about 36 mils per minute. So we know the patient's on gabapentin for the neuropathic pain. What or if any dose adjustments would you make to the gabapentin dose? So your options are to leave it as it is, so keep it at 600 3 times a day, reduce it to 300 3 times a day, or reduce it to 300 once a day. Okay, so the majority of you have said to go with reducing to 300 3 times a day, and about 38% of you have said no change. So what we would do in practice, based on our in-house guidelines, and based on the 36.7 mils per minute of a level 1, we would reduce to 300 milligrams 3 times a day. So this is just to give you an idea of the table that we use on our guidelines for gabapentin. So the patient falls estimated here, so we would give 300 3 times a day. Now thinking about the antibiotics, what dose adjustments would you make to the ceftazidime? So this is, we're on day 3 now. So would you keep the patient on the 2 grams 3 times a day? Would you reduce it to 2 grams twice a day, or reduce to 2 grams once a day? Okay, so the majority of you have said reduce to 2 grams twice a day, which is the correct answer. For those of you who have said keep at 2 grams TDS, so in practice, what we do here at UCLH, and generally for our critical care units, is we do tend to keep the patient on a full high dose for at least the first 24 to 48 hours. And then we would reassess the renal function. So with this patient, we saw, after day 2, day 3, renal function continues to worsen. They are on a filter, creatinine's worsening, but we tend to then dose reduce after the first 2 days. And the reason for that is we want to give them, a full dose, like a good load of the antibiotic to work while they're in critical care. So, they're very ill, likely to have a very severe infection. So we want to give them as much of a dose as we can in the first few days where they're the most sickest, and then we would look to dose reduce. As mentioned, we would dose reduce as per the predicted clearance on the filter and our renal guidelines. Other things we may look at for antibiotics. So if you have a patient who is on antibiotics that you can check levels for, so things like gentamicin or amikacin, then we could look at the levels as well to kind of guide us with the dosing. And the caveat to this is just to remember that we would need to think about the patient's weight. So, if they're really, really heavy or very low body weight, would that affect the dosing that you give? How septic the patient is. So sometimes it might be a discussion with the consultant and the microbiology team. It could be day 3, day 4, and the patient's very, very sick. And we might not want to reduce the dose of the antibiotics, even if the renal function is bad. So you would have to look at severity of infection and also how toxic the drug is. So if you are giving a drug that has, lots of side effects, very nephrotoxic, you might not want to then carry on a full dose for such a long time. But if it's a relatively safe drug, you could possibly consider it with discussion with your critical care team. So this is just an example of our renal guideline that we have within critical care. So with this case, as we mentioned, because the estimated renal function is between this range, we would then look to reduce to 2 grams twice a day after the 3rd day. So a few more scenario-based questions. Again, happy for you to answer on Slido or come onto the mic. So you have a patient who has started on a new antimalarial called Urotism, and that's a mix of piperacin and artenomol. So this patient's also on a filter. It's a new medication, therefore you don't have enough information on renal drug dosing. So what considerations would you need to think about when you're thinking about, can you give this drug and the type of dosing that you would need to give on a filter? So what considerations would you need to think about? Okay, so lots of good answers coming through. Protein binding and size as a molecule, definitely probably the biggest and most important factor you need to think about. When you have drugs like this that you won't find in the renal drug database or in your local guidelines, you will have to go back to pharmacokinetics and pharmacology and think about the drug. So protein binding, does anyone want to explain why that is important when you're thinking about drugs and renal replacement therapy? So we did mention it briefly at the beginning. Why is protein binding important? Any thoughts for those of you who said protein binding? Anything in the chat, Razi?
No, nothing at the moment.
No. I mean, I'm happy to talk through why. So if you think about the slide that we talked about with regards to the size of the molecules, protein or albumin, which we have in the body, is a very large molecule. So it's more than 50,000 Daltons, which means it's difficult to be cleared by the filter. So if you've got drugs that are very heavily protein bound, they're not going to be cleared by the filter. So then you might need to think about the dose, dose reducing, or is it going to be effective if you've got a patient on a filter? Size of the molecule, again, similarly, if the size of this new drug is, less than 50,000 Daltons, it will be cleared by the filter. And so will that be a problem? Would you then need to increase the dose? You do need to also think about if the drug is already nephrotoxic. So, do the trials or side effects show that it already can affect kidney function? Just seeing what other answers people have got. So yeah, essentially you would have to think about the pharmacokinetics. If it's protein bound, the size of the molecule, is it already nephrotoxic? And the type of renal replacement therapy being used. And the one that I've been talking about today is a continuous hemodiafiltration method. Obviously, the type of method that you use at your hospital, you need to look at how it works. Is it over 24 hours? And what size of molecules does it clear? And then, so you have to kind of go back to basics of pharmacokinetics. So that's sometimes in practice, we do actually get these odd queries. So this is based on a real life query that we had a few weeks ago. And so it's just good to know kind of how to work it out. Toxicity is also important. If it is a drug with lots and lots of side effects, and you know that it's not going to be cleared by the filter, you might have to think about, is there an appropriate alternative or not? There are lots to think about. You could also ask the manufacturer if there is any new data since the drug has been out, if you're really stuck. And so, yeah, that could also be an option. Few more scenario-based questions. So you have a patient on continuous renal replacement therapy, and it's just for fluid overload. So if you think about the pre-recorded material that we have, there are different reasons of why we place patients on a filter. And one of the reasons is fluid overload. So they have a normal creatinine and renal function. Would you need to make any drug dose adjustments in this patient? So they have a normal creatinine, normal renal function. Okay, so we have a mix of answers here. We've got some who are unsure, some who have said no, and some who have said yes. So actually, in practice, it probably is a mix of all these answers, dependent on the drug. In theory, the patient has a normal renal function. So actually, depending on which drugs the patients are on, you may not need to make any drug dose adjustments. So the purpose of the filter for this patient is just to remove excess fluid only. The kidney is working as normal, they're producing normal urine output, and so you wouldn't need to make any drug dose adjustments. So I guess the caveat is dependent on the drug, but in practice and in theory, you probably wouldn't need to make any drug dose adjustments, but it would be a discussion that you would need to have with your critical care medical team as well. But we have had situations like this where, everything else is normal and functioning, and so we wouldn't actually make any drug dose adjustments. Another scenario that we do have that comes up in practice is patients who need to be mobilized. So the physiotherapists ask us, we want to allow the patient to have some time off the filter in the evenings. How could this impact on drug dosing, and what considerations would you need to make? So this does come up in practice for us. It's interesting to see what people's thoughts are about this situation. Okay, so really, really good answers coming through. Again, this is the type of scenario where you would need discussion with your medical team. And yes, it does depend on the drugs that the patient is being prescribed. So, are there drugs that are cleared by the kidneys? Can they increase the risk of bleeding if you continue to give it and they're not cleared? Are they kind of time critical medications? There was an answer, someone mentioned the time their patient's off renal replacement therapy, and that's a really good point. I mean, if the patient's only mobilizing for 15 minutes, for example, it might not make much of a difference. But again, we do need to think about things like long half-lives and short half-lives. So depending on the drug that the patient's on, that half an hour may make a difference. I like the idea about giving lower doses in the evening. So yeah, again, depending on which drug you're giving, whether it's, given multiple times a day or can you adjust the dosing? Is the patient going to be mobilizing every evening or is it just one evening? So lots of considerations to think about. And as mentioned, it will be an MDT discussion, with your physiotherapist, with your medical team, and looking at which drugs the patient's on and how critical they are, how time critical they are, how the half-life, as you've talked about, and the dosing. And how ill they are. I mean, in this situation, if the patient's well enough to be mobilizing, it might not be so critical as a patient who is on, lots of antibiotics for a severe infection and that kind of thing. So yeah, good things to think about for your patients. Another scenario-based question that we do get in practice. So you've got a patient with a very low body weight of 41 kilos. And I guess what would you have to consider with this patient when you're thinking about renal dose adjustment? So sometimes you get the extremes of body weight, so patients over 100 kilos, but what do you do if you've got someone with a weight of only 41 kilos? Any answers in the chat, Rosie?
Not at the moment, no.
No, this answer's probably very.
I think the Slido is still showing the previous question.
Oh,
They're not able to use it.
Let's see if I can go back. Hang on. I think it's frozen actually. Okay, can you see it now?
I can see it. Can
Hopefully
everyone
you can
see
see
the
it.
screen?
Yes,
everyone can
perfect.
see it. Yeah.
Okay. It's a very similar question to a few of the others we've had, but it's, I guess, thinking about someone with a very low body weight as opposed to a very high body weight, and what would you do? Okay, again, good answers coming through. I liked it. I like the one about seeing if it can be dosed based on body surface area. Yeah, I mean, depending on the drug, that could be useful. Urine output, definitely one of our first go-tos. I'm actually very curious about this cystatin C. I don't actually know anything about this. I don't know if someone will be happy to come onto the mic and explain what it is and how it works and how you use it, out of curiosity. Anyone that uses cystatin C?
Hi, we are from Germany. We use it because it's basically just a different marker that isn't renally cleared and can be used in when patients don't actually have any creatinine because they have no muscle mass left.
Yeah.
So that's when we do it. Like we use it for our weaning patients that have been on a machine for a long time and haven't been able to move and therefore don't have much muscle mass left.
Okay, and would you use it? Is there a kind of formula that you would use to calculate the renal function, or you just use that as a marker?
Our system does it for us, so I don't actually know what the formula is, but basically it's just put in and then we're basically getting a number and using it.
Very interesting. I wonder if it's something that we need to look at in the UK.
It's for amputees as well.
Mm-hmm.
Oh yeah, that's a good one. Yeah, amazing. Thank you for that. And then my final question is a concept. This is more just to see if anyone's actually heard of this concept and if you do anything in practice. What is augmented renal clearance? Okay, so it sounds like lots of you have heard of this this concept, and it is when the kidneys essentially filter the blood faster than normal, so you're getting a higher clearance than usual, and it is usually defined when you have a creatinine clearance over 130 mils per minute. We do tend to see it in critical care, not very commonly, but we do see it in sometimes our young patients who are otherwise quite healthy. Burns patients, patients with major surgery, sepsis patients, are more commonly seen in males than females. And the kind of mechanism behind it is that when you have an acute illness, as you would on critical care, there is a strong inflammatory response that's produced, which increases your cardiac output, and this in turn actually increases your renal blood flow, which then increases the GFR. And why is it important in critical care? So lots of drugs, as we mentioned, are cleared by the kidneys. And if you have a higher renal clearance, you're losing this drug much faster than expected, which means you might not be getting a therapeutic level for these drugs in the body. So your standard dosing may not actually be enough for these patients. So we have had a few situations where we might actually look to increase the dose more than what our usual would be. So for example, I'm trying to think of one we've had recently, perhaps meropenem. We tend to go with a dose of 1 gram 3 times a day sometimes. And we have actually increased it to 1 gram 4 times a day if we felt that the patient had augmented renal clearance. We don't actually test for this in our hospital. I know that you can take, hourly urine outputs and monitor the creatinine hourly. We don't actually kind of have this system in place in our hospital at the moment. So we would just look at the creatinine clearance. and use that as a guide to see if it is something we need to be worried about, or are they on any drugs that are renally cleared that we would think about increasing. But in practice, we don't actually do the full investigation of doing the hourly urine collections. Does anyone on the call actually, collect hourly bloods or hourly urine, hourly creatinine to kind of monitor for augmented renal clearance? Or is that something that you've seen commonly in the ITUs that you've worked at?
Some do, but they say the practice is not very common.
Yeah, so sounds like how it is here. It's not a common practice, but it could be something that we look to in the future. And I guess if you do notice, your patient's not actually responding to antibiotics, or the levels are coming back very low, that could be something you need to have a look at and think about for your patients. And then I'm just going to end on some final thoughts with regards to renal replacement therapy, and I've just popped them on the slide there. So when we're thinking about dosing for your patients, you have to obviously think about the type of renal replacement therapy, what rates they're on. Urine output and trends, very important, especially if you don't have things like creatinine as a marker. Limitations of studies I put on there because there are quite a few studies that talk about the different types of renal replacement therapy. But when you are interpreting them, you need to think about, is the population they talk about relevant to where you work? Is the type of renal replacement therapy they're referring to the type you use? So you can't always extrapolate the data. So bear that in mind when you are looking at studies. Caking on filter, I've just put on there as I guess one of the cons. So we do sometimes need to take patients off a filter if, when I talk about caking, it's a little bit like when you have lime scale build up in your kettle, it can stop the filter from working properly. And so in that case, sometimes we just take the patient off the filter if we need to. And when to come off the filter is a topic of debate that we do have amongst our critical care medics. I guess you have to think about why you put the patient on the filter in the first place. Are those markers improving? Is their condition improving? How well are they? How well are they not? And that kind of thing. So again, that's something you would have to discuss with your team. And there's no real right or wrong answer with that. It's all patient specific, patient dependent. And that's my final slide. So hopefully that was insightful and you've learned a lot. And hopefully you've been able to apply what we've shared on our pre-recorded material. Razi, do you have a question?
We just have one question.
Yeah.
So the question is, which resources do you use for dosing augmented renal function?
Good question. We don't actually have a resource. What we would do is we would just kind of do an estimate and increase the dose where we would think it would be safe to increase the dose. So for example, with meropenem example, we know that you can give up to 2 grams TDS. So if the patient was already on 1 gram TDS, we know it'd probably be safe to increase it by, one further dose, for example. I don't know actually of any resources where they give you dosing advice. So I think it's something that you kind of have to trial and error with your microbiology team or with your critical care team. Any other questions?
I think that was the last question, unless anyone has another question to ask.
Amazing. Thank you all for attending, and look forward to seeing you on next month's session. And we will be uploading this recorded session hopefully in the next couple of days that you can look back on. Thank you so much, everyone.
Thank you, everyone.
Bye-bye. Bye.
Bye-bye.